I'm Gutschmidt. I'm with the chemical team. I have been with the organization for nearly 20 years, working on different environmental health and chemical issues. My involvement in chemical risk assessment is first related to emergencies. I've been doing rapid risk assessment in emergencies from the desk, but also in the field. Secondly, we are developing guidance material for emergencies, but also for regulatory purposes, where we're dealing with chemical risk assessment. And as part of that, I'm also involved a lot in capacity building activities. As part of that, we have developed quite a few case studies on chemical risk assessment, which could be of interest to this project as well.
My name is Ms Tempowski. I'm also in the chemicals team with Kirsten. I've worked at WHO for about 12 years. And my main area of work is on poisoning and on poison centres. So before coming here, I used to work for a Poisons Information Service where we did clinical risk assessment every day. Now that I'm at WHO, as with Kirsten, most of the work that I do on risk assessment involves helping countries to deal with emergencies.
Yeah, as I mentioned earlier, I've been conducting risk assessment in the context of emergencies in the field. The last examples where we have done investigations in the field were in Angola, which was in 2008. So the event appeared as an event of unknown etiology, so the doctors on the ground were not familiar with the signs and symptoms. They asked for toxicological assistance. We sent a team in and we did a number of investigations, including collecting samples, urine and blood samples. This was a mix of environmental epidemiological investigations and classical risk assessment methodology, how we use them in chemical safety. The challenges on the ground were really that although we collected blood and urine samples, we had no laboratories in the country. We had to send them out to laboratories in the Western world. That is a very challenging part, starting from collecting the samples to getting them through customs, to identifying laboratories in the Western world, accepting them to analyze them on a short notice and feed us with the information. We have been to other countries. In Mongolia, for example, there was a chemical accident where we knew it was related to gold mining, and there was a release of a mix of substances, including mercury and cyanide and so on and so forth. The very challenging part here was that it was in a very politically sensitive information. So as a result of that, there was a high mistrust in the local population and local government. And as a result of that, international community was mobilized to do neutral assessments. We were mainly surrounded by cameras and TV, every night on TV, and every party presented its own version of the thing, depending upon how they looked at it. In addition, it was really multidisciplinary and multi-sectoral. So it was the health sector, with the animal health sector, with the environmental sector, with the food sector. So emergency people were involved. So to give you a feeling, at the end we were a team of about 60 people in the field, involving all the different disciplines and sectors. Apart from the risk assessments in the field, as I said, we have done a lot of capacity building activities, and there we have developed case studies for training. I might give over to my colleague.
I think probably the main points are that when trying to do risk assessment for a chemical event is that there are a lot of unknowns, and it takes a lot of time to find the information that you need to do the risk assessment. So we often sometimes by the time we are informed and our assistance is requested, the chemical has already been and gone. And there may not be anything even left to measure in the people. But they will, then, as Kirsten said, finding the laboratory is very time consuming. So it can be quite a complicated, drawn out process, at the end of which you may not even have a very firm answer.
Yeah.
And as Kirsten was saying, when you have a politically charged situation, people don't want to hear that you don't have an answer. They want to hear that you have an answer. So I think that's. I think it's relative. I think it's easier to diagnose an infectious disease than it is to identify a chemical cause, and to then assess what the risk of that is, because of the huge number of chemicals that there might be, the lack of laboratories.
Yeah. So we have mentioned the laboratories. That is challenging to identify the laboratories. We know about laboratories, but the most challenging part is that the laboratories accept the samples and analyze them on time. That is very critical, because these are usually laboratories set up for other purposes. If they get now 100 samples in, and sometimes they have to add some research to it. For example, they can analyze something in bananas, but not in soil. So that would require some research. So it's some effort by the laboratories, and that should be set up beforehand in principle. And John, I think you agree that the clinical toxicological expertise which is in the world is not that big. So basically, if we had many chemical events in a row, we cannot come back to always the same people. Yeah, our expertise, we're talking about a few people only who we can mobilize, and who can act also even on behalf of WHO in such an emergency setting. So, as a matter of fact, I believe that in a developing country context, especially, for example, in Africa, we have very good doctors, but these doctors are very familiar with infectious diseases. So if they see signs and symptoms which they are not familiar with, then they might think of a different cause of a disease. That was one of the very early trigger points in the Angola event, that the doctors familiar with the infectious diseases in the country haven't seen this before. That's number one. But number two is really that some signs and symptoms exclude maybe an infectious disease, while other signs and symptoms favor a non-infectious disease or chemical-related etiology. And I think that is what happened in Angola as well. I think we didn't see any fever, for example.
Yeah. So fever is a common feature of an infectious disease, but it's a relatively uncommon feature for a chemical-related illness. There are some chemicals that cause elevated temperature, but you don't tend to see hundreds of people, as in Angola. I mean, if you saw hundreds of people with an elevated temperature, you wouldn't be thinking chemical, you'd be thinking infectious disease. Of course, from poisonings, you can, in a group of people, have some people with a fever because they may have a concomitant infectious disease anyway. They might have malaria, for instance. I mean, we've certainly seen cases of mass poisonings where there are a proportion of people with elevated temperatures because they've got malaria, or they've got another disease that's endemic in the area. But if you've got a lot of people, hundreds of people in Angola were essentially asleep, and then woke up a few days later, and then recovered fully, that characterises a chemical, I think.
Yeah.
Whereas if it was some kind of disease process, people wouldn't just wake up in 2 days and be back to normal.
Yeah.
So because people waking up, that what that says is the chemical has been metabolized, eliminated from the body, and it no longer has an effect.
First, also the distribution of cases can give some indications. So in Angola, for example, there were mainly the children in the huts, sometimes the mothers, but rarely the fathers. So, and then it was not a cluster of huts, but the people affected, they lived partly apart from each other. So maybe for infectious diseases, you would, because of transmission and so on, so you would expect a different pattern. That can give you an indication. So the cases were concentrated in a hospital. In a hospital, they were treated, and so the chemicals were excreted and metabolized or whatever, and they become well again. So they came back to the community, and a day later they became dizzy again, they fell asleep, they were like in a coma type of thing. So that can give you also the idea that there was an exposure. The exposure was disrupted during the time of the hospital, and when the people came back to their homes, exposure started again, and in fact that was the case. So the signs and symptoms, fever or not, for example, the pattern, maybe hearts or families or partly family, the children, for example, because they have small body size and weight, or disruption of potential exposure. These are all indications which can give you a clue as to whether a chemical is being involved. And for experts, it can give you also a clue what type of chemicals, especially when we talk about the signs and symptoms.
I think on the what kind of chemical side of things, though, that can be a challenge, because with Angola, when we looked at all the chemicals that can cause CNS depression, well, there are hundreds of drugs for a start that are CNS, well, not hundreds, but a lot of drugs that are CNS depressants. Organic solvents cause CNS depression. I mean, there are just lots of chemicals, and trying to narrow it down and identify the chemical that caused the illness, that involved a bit of detective work as well as extensive laboratory analyses.
But even the laboratory analysis is very difficult to get it in a low resources type of context, because especially where you haven't identified the chemical hazard, you ask the laboratory to analyze for a substance. But when you're not sure about the substance, you have to run surveys of groups of substances or groups of drugs, and not all laboratories have this capacity in place. I mean, this is very challenging.